Let me take this opportunity to welcome all of our guests here this evening. As Jed indicated, this is the third meeting that we have had to discuss the problems that we are concerned with, which are primarily the accessibility of health care for citizens in the state of Vermont and the affordability of health care for people in the state of Vermont and in our area. I think the reason that we put together this task force is that we recognize, and I use the word advisedly, that we have a crisis in both the affordability of health care and the accessibility of health care. The cost of health care throughout the nation and in Vermont is zooming upward and has been doing that for the last 20 or 25 years. We are now spending as a nation about 11% of our gross national product, and what the experts indicate that if present trends continue, we're going to be spending considerably more than that. Everything being equal, the cost of doctors' bills will continue to rise markedly. The cost of hospital care will continue to rise markedly. Right now, 15% of our people can no longer afford any health insurance whatsoever. And for many other people, the cost of health insurance, whether it's Blue Cross, Blue Shield, private insurance, etc., is taking a very heavy chunk out of their income. Some of you may have seen, I don't want to frighten our senior citizen friends too much, the front page of the Rutland Herald today, and I guess it was in the New York Times as well. Let me read the first paragraph, very sad paragraph. The Reagan administration has told Congress that it plans to increase the premiums paid by Medicare beneficiaries by 38.5% next year, mainly because the cost of physician services for the elderly is rising much faster than had been expected. All along, it is the Reagan administration's position that the poor people, the elderly people, working people are going to have to pick up the increased cost of health care, and no one is asking the very hard questions. Why is health care going up as fast as it is? Why is the cost of health care in America, the United States, increasing a lot faster, for example, than it is in Canada? What about the drug companies making billions of dollars, et cetera, et cetera? I can go on and on, but the hard questions are not being asked, and one of the goals of this task force is to, in fact, try to ask some of the hard questions. Let me conclude simply by saying this. The truth of the matter is, and I don't want to be hard on our own state, I think it's true all over the country, we have not been asking questions like, do we in fact in the state of Vermont have a healthcare system? Or do we have a major hospitals and a lot of smaller hospitals and a lot of physicians each going along their merry way in a more or less competitive attitude, rather than saying, how can we as a small state, we're a small state, provide the quality of health care that we need at rates and costs that the people of our state can use? One of the major areas of concern is that with 15% of our people not able to afford health care, the interesting point is the vast majority of that 15% are not unemployed people. They are working people. And what is going on as the service industry employs more and more people, and as the manufacturing sector employs less and less people, the union jobs are disappearing. And instead of workers having decent health care packages, such as they do at the City of Burlington or UVM or the state government or GE or IBM, what you're having is people working for the McDonald's and the Burger King companies. So they're getting low wages, and they're not getting, by and large, decent health care packages. Now, who should pick up that? Should it be the taxpayers who pick up that expense? I don't think so. Have we as a state begun to look at the issue as to whether or not somebody should mandate that the service industries themselves have got to start providing health insurance to the people? Okay? The relationship of state government to the UVM Medical School. It is an extraordinarily important issue, but I fear that too many of our public officials are afraid to address the issue. How many of the people out there know that you as taxpayers are contributing about $6 million a year, $6 million a year to the UVM Medical School? Do you know that? I would say 98% of the people in the state of Vermont don't know that. Probably the majority of the people in the legislature don't know that. What are you getting back for $6 million of taxpayers' money to the medical school? Are you getting free clinics from state-funded physicians? Are you getting physicians going out into the rural areas of the state where they're needed? Are we getting public health doctors? And the answer is, by and large, no. There is very little accountability on that issue. All right, let me simply conclude by saying that the issue of health care is complicated. There is no simple answer. I don't think any of us think that we know a magical answer. But there is a crisis. And the bottom line, from my point of view, is There is a direct relationship between the affordability of health care and the accessibility of health care. If you're concerned about people's health, you've got to be concerned about the affordability, because if people can't afford health care, they're not going to be able to go into the doctor's office, they're not going to get their prescription drugs, they're not going to be able to go to the hospital. We have got to deal with this problem. An essential part of the problem is that the health care industry is a very powerful political force. And I think sometimes when we look at healthcare providers, we're gratified by their knowledge and their work, but also, and that's important, many wonderful people in that industry. On the other hand, there are a lot of people in there who are making a lot of money, and we've got to look at that as well. That is the end of my remarks. I thank you very much for coming out this evening, and I hope the discussion will be interesting and provocative. It usually is. Jen?
I believe our last speaker for the evening is Jim Leddy from the Howard Mental Health.
I'd like to present some thoughts dealing with the more severely handicapped and disabled of the people that we deal with in our agency and other agencies like ours around the state. And that is the mentally ill and the mentally retarded. I think that there are three significant and interrelated barriers that we must deal with and respond to today. Clearly, one is stigma. People who suffer from mental illness, people who are mentally retarded, are dealing with stigma. They're dealing with it, and their families are dealing with it. It is not so long ago that people and families who had a mentally retarded or mentally ill family member, quite literally, that family member often was kept in the closet, in the back room, or sent to a state institution. While we've made substantial progress and real change in so many of those areas, one of the concerns I have is that we may have deinstitutionalized on one level, but we at the same time may well have simply moved the institution to the community. And we need to understand that, because if we have only taken people from Waterbury and put them into a group home in Burlington, if we have only taken them from an institution and put them into a program where they're transported to the program by staff of Howard Mental Health, where they participate in work programs run by Howard Mental Health, where they live in homes run by Howard Mental Health, where they don't associate with many people other than the staff of Howard Mental Health, then we have not succeeded in bringing people back to the community. We have not succeeded in providing what they need in the community as part of the community. And that's a critical, critical concern and a major issue that needs our attention. And I frankly think that we as providers have not done a very good job around some of those areas. The second point I'd like to make, along with the stigma and that of attitudes, is that of education. To follow up on the stigma issue and on bringing people back to the community or keeping them in the community, I think we as a provider, I'll speak only for my agency, I don't think we're any different really, we haven't really done a very good job at telling the community, at telling you what we do. We haven't done a very good job at telling you what's needed. The other side of that is you, not speaking personally, but you as representatives and you as the community haven't really asked us what we're doing and what we need. We haven't told you well enough of the needs of the people we serve, who often are severely disabled. And often the easiest and the most effective thing we can do on one hand is to provide treatment, rehabilitation, habilitation. But if we don't respond to their housing needs, if we don't give them something meaningful in their lives, the same things that are meaningful in our lives, employment, meaningful activity, relationships, if we do not respond to those basic human needs of shelter, of relationships, of meaningful activity, then we really are begging the question of providing the care that's truly needed. We've made great progress, and I don't want to downplay that. But we really have a long ways to go towards truly integrating people into the community, integrating handicapped and severely disabled people into the community, into their families, into employment, into education. We've probably made more strides in education for the mentally retarded with special ed than in any other place. But while we've educated people, They complete their educational program, there's no place for them to go. There's no day activity program, there's no jobs to place them in, even though they may be trained and skilled and able to do work. We're backing up every single year in Chittenden County 30 to 40 to 50 people who have never been away from their families, who have been educated and well educated for the most part in our school system through special ed, and they finish that program and there's no place for them to go and nothing for them to do. We're wasting people's lives and we're wasting money. I know that when we go around and try to deal with housing issues, right now Howard Mental Health is providing housing for about 165 mentally ill and mentally retarded people in the community. The most positive aspect about that is that just about 120 are either living in their own apartments, 90 of them are in their own apartments with as little or as much supervision as they need, but they're living alone, not with staff. Another 30 we've been able to place with families, trying to move away from a staff setting, trying to move into as normal a relationship as possible with people who will take them and care for them as part of their family. When we go into neighborhoods and say we want to put a group home in a neighborhood, even if it's for the retarded, we generally get two responses. The first has to deal with safety, personal safety. Will they be violent? Will they harm our children? The second is more subtle, more insidious, more damaging. What will it do to our property values? When we deal with property values and not human values, when we devalue the most disabled and the most handicapped and the most vulnerable in our society, then it's difficult to see how we can develop the type of overall response to the health care, to the human needs of the population at risk in our society. I don't really believe that Howard Mental Health or any agency such as ours should be the provider of last resort or the provider of only resort. But too often that is the case. We run employment programs. We have our own janitorial company that will be glad to respond to your offers to bid on any work you have. At times we've been accused of competing with the private sector, with other private services. My response is quite simple, basic, and fairly challenging. If you will hire our people, we will train them, we will work with you, we will work with them, we will follow them in their job. If you will hire our people, we will get out of business tomorrow. The other side of the educational coin, away from what we have done to educate the community, some risk as I look at all these PhDs and MDs and tied to the academic world, I think the academic world has not been responsible in training people to respond to the needs of people in the healthcare system. How can professionals be trained for inventive systems when the teachers are too often far distant from those systems and from the realities of the real world? You asked, Bernie, what might the University of Vermont College of Medicine do with $6 million? I don't think it would take $6 million. There are several areas, just in that one particular professional training program, that I think could be utilized to great benefit to the community and to the health of the population. Dr. Stanley Gitlow is one of the few physicians in this country who knows anything about the treatment of alcoholism. And he once said that he called it the 3-4-quarter program, 3-4-quarter training program. He said he received 3 hours of alcohol education and 4 years of medical school to prepare him to deal with 25% of his patient load. I don't know if there's much difference today. When the state of Vermont passed a mandatory alcoholism insurance bill several years ago, if you read in the preamble of that bill, it speaks to one of the purposes is not just to provide coverage for alcoholism, to provide it in appropriate settings, non-medical if possible, but also to work closely with the resources of this state, in particular with the University of Vermont College of Medicine, to train physicians on how to diagnose and treat the disease of alcoholism. Today, as far as I know, there is no such comprehensive or specialized program available at this teaching university. I have been dealing with this particular issue for 12 years, and the response today is the same as it was 12 years ago. We may have to wait another year. When it gets time to training for physicians in the area of psychiatry, for a number of years, the psychiatry training program basically did not have residents rotate through state hospitals, did not have them dealing in a long-term way in their training with those that are most severely ill with the area that they were going to be working with. That has changed in the last year, and the program is now back online working at the state hospital, but you have to question where we're going if we have training programs that fundamentally move away from training people to deal with the most disabled of a particular illness. I think we have some other complications in this area of education. One is somewhat compounded by the various disciplines that get involved, especially in the mental health area. And we're facing it in some levels with who can be reimbursed for care. We're also facing it with credentialing and other issues, and that's really a two-edged sword. While we really need people of high quality, of top-notch training, who are trained, who are accountable, I think at times we may wonder and get caught up in perhaps some professional differences or rivalries that frankly ultimately affect the quality of care of the people that we're serving. We too face a shortage of finding and keeping qualified people. A person with a master's degree in social work coming to Howard Mental Health to be an alcohol counselor or provide outpatient work will start at about $15,000. A teacher in South Burlington coming out of UVM with a bachelor's will start at $20,000. An alcohol counselor for the state of Vermont without a graduate degree will start at $19,000 or $20,000. A social worker at the Veterans Administration will start at $21,000. I could go on and on to cite comparisons not only with other professions but with workers in other areas. This is a real problem. To some degree, we have benefited simply by the fact that we're located in Burlington and that there are people who have trained here, who want to stay here, and who are willing to make the sacrifices. But we're starting, especially in this economy, to find it very, very difficult to find people at entry-level jobs and to work in our residential programs. The funding issues are complex, and I saved them for last not because they aren't important, but I frankly think the other issues probably lead up and cause some of the funding difficulties. We mentioned, Dr. Terrace, I think you made reference to the issue is not only a federal one, but what is the state of Vermont, what is happening from a financial standpoint, and to really start to question where the priorities, not of the federal government are, but where the priorities in this state are at this time. Obviously, I could say that the funding is too little. I think we have been dealing with a form of creative starvation for too long, and it can have over time a very serious effect on the availability of services as well as the quality. We have waiting lists for every single service that we offer in mental retardation. Unless a person goes into acute crisis, we are not going to serve a new client because we don't have the resources. And in fact, we're losing money in those areas every single day. It's a terrible commentary. We have people waiting at home who have completed good programs and can't get services because there's nothing available. Our crisis service, which we operate jointly with the medical center, is staffed as it was 4 years ago when we merged. When we projected we would deal with 7,500 situations, this year we'll deal with 12,000 with the same number of staff. When people, our cooperative apartment and housing programs have waiting lists. When a person is on a waiting list for an apartment, they're generally staying longer in a group home than they need. They may be staying at the way station. If they are staying longer in a group home than they need, that means someone's staying longer at the state hospital than they need to stay. There are probably 20 people from Chittenden County at the Vermont State Hospital today who are only there because we do not have resources to bring them back to this community. It's not a question of what they need in the hospital. It's a question that there's nothing available in the community to serve them. The type of financial cost attendant to long-term mental illness or lifelong mental retardation could be termed catastrophic when it impacts on families. And we cannot and should not look or expect families to be able to deal with not only the personal pain and the difficulty of trying to get educated and overcome the stigma, but also to deal with financial costs which they simply cannot afford to bear. That's a reality. Too often the funding, unfortunately, is based on stigma and labeling and on a person's disability. Too often it's influenced by the whimsy of federal politics or who's in office and what they believe today. It's also affected by changes in other parts of the healthcare system. When the hospital system rolls or tips or burps, the rest of the healthcare system erupts and bounces off this and that simply because of the overall impact. We have a funding mechanism for most of our services that is irrational. It's based on a medical model and reimbursement mechanisms which are tied to that medical model, which are best are too narrow and at worst totally irrelevant to the needs of the clientele. The funding for the services must respond to the needs of individuals and not to mindless regulations or maintaining institutions. Too often, these restrictive funding requirements mandate inappropriate and inadequate services. I can tell you there are regulations which we have to adhere to, or we're told to adhere to, that, for example, will say that if it's Title 18 or Title 19, the Medicare and the Medicaid program say that we can only provide psychotherapy to an eligible client in an office if a psychiatrist is in the building at the same time, and it better be the psychiatrist who's overseeing the care for that person. It's impractical, it's irrelevant in terms of what they need, and it severely limits the type of response that you can give to a person who has multi-needs. We're dealing with vocational and day programs that Medicaid has said they will not fund. We're dealing with major cutbacks in those program areas because of Medicaid withdrawing funding support for programs because they say that's not a medical program, that's a vocational program. We say, well, help get a person a job, and they may not need the same level of care. Well, that's a wonderful goal. Why don't you find another funding source for that? As administrator, I often lie awake at night praying to the great auditor in the sky, simply, please don't let these auditors come around until the statute of limitations has expired. We absolutely cannot operate and provide necessary, relevant, and appropriate services under the regulations that the federal government imposes. And many times, frankly, we don't. And we run great risk at that. In the state of Vermont today, if the federal government came in and did audits on some of the programs, truly audited them, there would be substantial penalties incurred simply because we cannot live with those regulations. One of the most important and frustrating problems has to deal with stigma and disability. I've never been in the position, but I think about it sometimes, of what it must feel like to prove how inept, how weak, how debilitated, how vulnerable, how incompetent, how incapable you are, so that you can be certified to receive benefits. Sometimes wonder how it must feel that once I am certified, to worry constantly that if I get well, I may lose the only stable source of security and of income and of benefits that I have. Have you ever thought of staying sick so that you can simply maintain your benefits? We have people who go to work and will work up to a certain point and then will quit because they're afraid they're going to lose their benefits. Probably the most frustrating point of all in this current era is to respond to the truly needy and to really decide whether or not there is in fact a safety net for the truly needy. The people that I'm talking about are at the mercy of unpredictable federal whimsy about who is a deserving disabled person and what is it that they deserve. A few years ago, we've heard Keith Kirkland and others talk about denials. We have to deal with that too. A few years ago, 3 or 4 years ago, a member of the United States Senate referred to the changes that were happening by regulation, by denial, by kicking people off their disability as nothing more than a holocaust against the handicapped. That senator was Senator Hines, a Republican of the state of Pennsylvania. It is more subtle today because the Social Security Administration has been prohibited by court order against following through on some of their denials and on some of what they've done to basically question someone's eligibility and then to put them through terribly painful, dehumanizing requirements to get their disability back. But they work in other subtle ways. They say you're certified, then they don't pay for the service. They deny it. I think in terms of some recommendations, I don't have any. I have a lot of frustration, a lot of feelings. I have a few recommendations. Some have been already made. Obviously, prevention and early intervention must be recognized and funded rather than forcing providers to choose between prevention and acute and long-term care. One of the most important changes is that we need more flexible and more benign, less stigmatizing funding dollars, which focus on needs rather than on regulations, that respond if this person has needs that include housing, that includes job training, that includes dental care, that includes they require outreach, that we're able to put together a package of services. Whether it's through a waiver program or some form of program, it makes no sense at my agency to put together a program to meet a person's needs and have to access 6, 7, 8 different funding sources to do that. And that often is the case. We need a better educated and more involved community. We not only want your money, but we want your bodies and we want your hearts. And we have an obligation to really do much better in that area than we've done, to educate people, to educate consumers and families and the community about what it is that handicapped and disabled people need to be sustained in the community. I frankly think that's probably our greatest challenge.